Moral anti-realism in healthcare ethics. When healthcare professionals disagree about what is ethically right or wrong, one possible explanation is not that one side has discovered the moral truth and the other has missed it, but that there may be no objective moral facts to discover in the first place. Moral anti-realism begins from this possibility. Moral anti-realism is a meta-ethical position that denies the existence of objective moral facts or values. According to this view, moral judgments do not correspond to mind-independent truths about the world. Instead, they are understood as subjective, culturally relative, socially constructed, or systematically mistaken. In healthcare ethics, moral anti-realism challenges the assumption that ethical principles are universally true or binding in all contexts. Rather than treating moral claims as factual assertions, anti-realism interprets them as expressions of attitudes, social norms, cultural practices, or shared agreements. This position includes several distinct sub-approaches. Moral relativism holds that moral judgments are true or valid only relative to a particular culture or social framework. What is considered ethical in one healthcare system or society may not be considered ethical in another, and there is no neutral standpoint from which to judge between them. Moral subjectivism locates moral judgments within individual attitudes or preferences. From this perspective, when a clinician says an action is wrong, they are expressing a personal moral stance rather than reporting an objective moral fact. Error theory takes a more radical position. It argues that moral language assumes the existence of objective moral facts, but since no such facts exist, moral statements are systematically false. This view is most closely associated with J.L. Mackie, who claimed that while moral discourse is meaningful in practice, its underlying assumptions about moral objectivity are mistaken. In healthcare ethics, moral anti-realism helps explain why ethical disagreement persists, even among well-intentioned professionals who share medical knowledge and professional commitments. Disputes about end-of-life care, reproductive ethics, resource allocation, or cultural practices often reflect deeper differences in values rather than disagreements about facts. From an anti-realist perspective, ethical frameworks in healthcare, such as codes of ethics or institutional policies, are understood as tools for coordination rather than discoveries of moral truth. They function to promote cooperation, reduce conflict, and establish shared expectations within professional communities. This view is particularly influential in pluralistic healthcare environments, where clinicians and patients come from diverse cultural, religious, and philosophical backgrounds. Moral anti-realism cautions against assuming that one ethical worldview has universal authority over all others. In clinical practice, this perspective can encourage cultural humility and ethical sensitivity. Rather than imposing a single moral standard, healthcare professionals are urged to recognize the legitimacy of differing moral perspectives and to negotiate ethical decisions through dialogue, respect, and contextual understanding. However, moral anti-realism also raises significant challenges for healthcare ethics. If there are no objective moral facts, it becomes difficult to explain why certain practices should be condemned universally. Claims that exploitation, discrimination, or abuse are wrong risk being reduced to expressions of preference or cultural disapproval rather than moral critique. In healthcare settings involving power imbalances, this can be especially concerning. Patients are often vulnerable, dependent, and unable to protect their own interests. Without some appeal to objective moral limits, it may be harder to justify strong protections for patient rights beyond institutional agreement. Moral anti-realism also complicates the idea of moral progress in healthcare. If ethical norms are entirely relative, it becomes unclear whether changes in practice represent improvement or simply difference. Historical reforms, such as the rejection of non consensual experimentation or discriminatory care, may be interpreted as shifts in values rather than corrections of moral error. In your healthcare ethics framework, moral anti realism occupies an important critical role. It forces students and professionals to examine the assumptions behind ethical language, to recognize the influence of culture and power, and to avoid simplistic claims of moral certainty. At the same time, the practice of healthcare ethics often implicitly resists full anti realism. Ethical committees, patient rights doctrines, and professional obligations frequently operate as if some actions are genuinely wrong, regardless of opinion. This tension is not a flaw, it is a feature of ethical reflection. Moral anti realism helps explain why ethical consensus is difficult and why humility is necessary, even as healthcare ethics continues to rely on shared moral commitments to protect patients and guide practice. Understanding moral anti realism is essential because it clarifies the limits of moral certainty, the role of culture in ethical judgment, and the challenges of ethical authority in pluralistic healthcare systems. It reminds us that ethical reasoning does not occur in a vacuum, but within social, historical, and institutional contexts that shape how moral claims are made and understood.